Hi there, my highly valued, treasured, and esteemed viewers and listeners, and welcome back to your channel of choice. My name is Dr. Nath Arwa. I am a clinical pharmacist by training and by profession, and I am the founder of Progressive Pharmacotherapy Consultants, a premier virtual clinical pharmacy institute for capacity building for healthcare workers. The virtual clinical pharmacy institute with a difference, where patient safety, medication therapy management, and optimal clinical outcomes are very, very crucial and non-negotiable to us. Here, we seek to remain your premier source of crucial tips for very high impact pharmacotherapy services. So I humbly urge you all to sit back and spare me part of your very precious time to share with you some very precious tips which may prove very, very handy in your line of duty. So I welcome you all to part 130 of our Pharmacotherapy MCQ series, Majoring in Infectious Diseases. The first question reads, Mrs. TMX, a 45-year-old female patient, is admitted to your hemato-oncology ward where she is receiving induction chemotherapy for acute promyelocytic leukemia, APL. The medical oncologist initiated her on idarubicin, all trans-retinoic acid, ATRA, and arsenic trioxide, ATO. She takes 200 milligrams of cefpodoxime orally twice daily prophylactically. And 8 days after this current admission, she develops a fever of 39.6 degrees centigrade, accompanied by rigors. She has no focal symptoms and has a normal chest X-ray. Some of her pertinent lab results include a WBC of 0 cells per microliter, a heart rate of 108 beats per minute, her blood pressure is 118 systolic, 78 diastolic, pretty low, and the urine culture obtained on admission turned positive for Escherichia coli, and it happens to be extended spectrum beta-lactamase producing. So my question to you is, which of the empiric antimicrobials listed below would be the most appropriate for patient TMX treatment now? Would it be meropenem alongside vancomycin? Would it be meropenem infused over 3 hours as monotherapy? Would it be cefepime infused over an hour as monotherapy? Or is it true that none of the antimicrobials is indicated and we should repeat temperature measurements in an hour's time? I'll give you 10 seconds to choose the correct answer. I would opt to treat this patient with monotherapy meropenem. Now, meropenem is a correct answer since TMX has neutropenic fever without any conditions requiring the addition of an anti-MRSA coverage. So we don't need vancomycin. That makes answer A incorrect. Now, she is colonized with the extended spectrum beta-lactamase producing Escherichia coli, and this should be included in the empiric coverage. Therefore, that makes answer C incorrect because cefepime, like many other cephalosporins, don't cover ESBL producing Escherichia coli. Then I would like to add that neutropenic fever requires prompt treatment, and a single oral temperature of above 38.3 degrees centigrade warrants treatment. So that makes answer D incorrect. Let's move to the next question, please. And it reads, Mr. AKM, a 33-year-old male patient who has been undergoing treatment for disseminated histoplasmosis for 24 months using Vifen, voriconazole, presents to your accident and emergency department with a chief complaint of epigastric pain, which has lasted 2 weeks. The emergency medicine consultant on duty would like to initiate Mr. AKM on a trial of therapy for heartburn and seeks your recommendation on the best therapeutic choice for Mr. AKM. So my question to you is, which of the medications listed below would you discourage the consultant from using for the management of heartburn in this clinical scenario? Would it be omeprazole MAPS? Would it be calcium carbonate TAMPS? Would it be famotidine? Or would it be pantoprazole? I'll give you 10 seconds to choose the correct answer. A is the correct answer. I would shy away from omeprazole. Now, omeprazole is an inhibitor of CYP2C19, the major metabolic pathway for voriconazole. Now, pantoprazole, famotidine, and the calcium carbonate do not inhibit CYP2C19, and that makes answers D, B, and C incorrect. And just like to add that voriconazole does not interact with divalent cations. So that makes C incorrect, but it would grossly interact with the omeprazole. And that makes answer A the correct one. Let's move to the next question, please. And it reads, Mr. PKM, a 30-year-old male patient, recently underwent a deceased donor renal transplant at your hospital due to a history of end-stage renal disease, abbreviated as ESRD, which was caused by focal segmental glomerulosclerosis, which is abbreviated as FSGS. Now, both Mr. PKM and his donor were seronegative for cytomegalovirus, CMV. So my question to you is, which of the CMV preventative strategies listed below would be the most appropriate for Mr. PKM? Is it A, no prophylaxis is required, or is it B, weekly CMV PCR with preemptive therapy, or is it C, letermovir 480 milligrams orally once a day, or would it be valganciclovir 450 milligrams orally twice daily? I'll give you 10 seconds to choose the correct answer. So A is the correct answer. This patient does not require any prophylaxis at all. Since he's at low risk. Remember, both the patient and the donor were seronegative. Now, valganciclovir is appropriate for prophylaxis in moderate or high-risk patients, and that makes answer D incorrect. And I would like to add that letermovir is not indicated for prophylaxis in solid organ transplant patients, so that makes answer C incorrect as well. Then I would like to add that weekly CMV monitoring is an appropriate strategy in certain moderate to high-risk patients, but not in the low-risk population like this particular, and therefore that makes answer B incorrect as well. Let's move to the next question, please. And it reads, Mr. IJO, a 67-year-old male patient, underwent an autologous stem cell transplant at your hospital For diffuse large B-cell lymphoma, which is abbreviated as DLBCL, at your hospital 6 days ago. His conditioning chemotherapy comprised of gemcitabine, Gemza, busulfan, melphalan, and panobinostat. Today, he has a grade 3 mucositis for which IV analgesia is indicated. During the past 3 days, he has spiked persistent fevers above 39 degrees centigrade despite empirically treating him with meropenem and vancomycin via the IV route at appropriate doses. Until 2 days ago, he was receiving prophylactic doses of fluconazole. So my question to you is, which of the pathogens listed below is the most likely cause of this case of invasive fungal infection in Mr. IJO's clinical scenario? Is it A, Trichosporon species? Is it Fusarium species? Is it Aspergillus species? Or is it Candida glabrata? I'll give you 10 seconds to choose the correct answer. D is the correct answer. Candida glabrata it is. Now, Candida glabrata is the correct answer in this particular case, as candidemia predominates in early post-transplantation period in autologous stem cell transplant recipients with mucositis. Now, this patient is in early post-transplantation and has not had prolonged or profound neutropenia, making invasive mold infections unlikely. And that makes choices B and C incorrect. And I would like to add that trichosporon is a rare yeast and is generally found in patients with prolonged neutropenia receiving a echinocandin prophylaxis, so it would be very unusual in this particular clinical scenario. That makes answer A incorrect as well. Let's move to the next question, please. And it reads, Mrs. FTK, a 66-year-old female patient with chronic lymphocytic leukemia, was initiated on alemtuzumab by your medical oncologist. My question to you is, which of the prophylactic regimens listed below would be the most appropriate for Mrs. FTK? Would it be valacyclovir and letermovir? Would it be cotrimoxazole alongside valacyclovir? Would it be cotrimoxazole or Septrin alongside valganciclovir? Or would it be cotrimoxazole, Septrin plus valacyclovir plus letermovir? I'll give you 10 seconds to choose the correct answer. Prophylactically, I would use Septrin, cotrimoxazole, and valacyclovir. Now, cotrimoxazole, trimethoprim, sulfamethoxazole, and valacyclovir are correct, since FTK is receiving alemtuzumab and therefore is at a risk for PJP pneumonia, herpes virus infection, and even CMV. Now, the NCCN guidelines recommend preemptive therapy for CMV rather than prophylaxis, so that makes answer C incorrect. And I would like to add that letermovir is only indicated for recipients of an allogeneic stem cell transplantation. That makes answer D incorrect as well. Then I would like to remind you that PJP prophylaxis is required. That makes answer A incorrect because there is no septin there to do PJP prophylaxis. So there you have it, my highly esteemed viewers and listeners. That brings us to the end of this video. If this video benefited you in any way, I would like to humbly remind you to give it a thumbs up, to like it, and to share it widely with your peers. And if you haven't yet done so, I humbly urge you to subscribe to my YouTube channel. I would like to promise you all that the very, very best is yet to come, and I thank you sincerely for viewing this video and for listening to me. I appreciate your partnership and your continued support and very kind collaboration, and I look forward to interacting with you in the next video. Thank you.